right. Well, once again, greetings from the GREC. I'm Christopher Jahraus. I'm a radiation oncologist and member of the Government Relations and Economics Committee of ACRO. And I'm joined by our usual Jason McKitrick, legislative advisor and advocacy specialist. And today we have a special new member who we hope is going to be joining us quite regularly, Scott Chen, from the Educational Enhancement Subcommittee of the GREC. So, Scott, tell us what you got in mind today, and sort of what the agenda is.
Well, thank you, Dr. Jahraus. My name is Scott Chen. I'm an assistant professor at University of North Carolina at Chapel Hill and co-chair of the Enhancement Subcommittee of ACRO GREC, and very honored to be here today. And as many listeners are aware, there have been many changes to the CPT codes for radiation treatment delivery this year in 2026, which has caused a lot of confusion for both providers and payers. And I was hoping we could have a somewhat informal discussion about these changes to keep our listeners informed.
Fantastic. So, where do we start? You want a little background on how this all came about?
Absolutely. I think some background from you and Jason might be very helpful.
Jason, tell us about how has ACRO worked longitudinally toward this?
Well, Dr. Uras, that is the right way to say it because this has been a long, long process. This has gone back more than a decade, I think, this new code set. And I think originally went to the CPT in 2013. And you saw some of the early stages and rulemaking a little bit after that, a couple of years later. And there were a lot of issues with that original code set that would have been really resulted in really significant cuts, particularly to freestanding radiation oncology centers. That's part of the reason that we were able to get the PAMPA legislation done that froze those rates for freestanding radiation therapy centers. And that bill also had a provision relating to an APM for an alternative payment model for radiation oncology that ultimately led to some ideas out of CMMI, the Center for Medicare and Medicaid Innovation, and ultimately that kind of morphed into the rocker legislation that we've been all looking at and supporting most recently. But concurrent with that, the new code set came online as of January 1 of this year for treatment delivery codes. And those codes actually link to the OPPS.
That's a first, isn't it?
That is a first, and it is, I would say, leans into some of the rocker concepts as well. But Dr. Uras, that's a kind of a very very summarized version of the last 10 years here.
And I think it's important that everybody know that this is the new codes are not something that ACRO and ASTRO or anybody else just got together and decided that, oh, we ought to do new codes just because we want new codes. No, it was really forced upon us, or mandated, I should say, by the AMA and in concert with CMS. And so, these are not things that we chose to do, but we had to do. And Scott, I understand that you've got three experts here with us. I'm the RUC advisor, but we have Dr. Thomas, our CPT advisor, and we have Ron DiGiaimo from R3, and also Teri Bedard from RCCS. So, Scott, I'll let you take over from here, and let's learn about this.
Well, sounds great. Thank you so much. I think it would be very helpful for us to perhaps focus on one of the treatment delivery codes, 77412 today, which is the highest level of billing requiring the greatest degree of technical expertise.
It's also the most misunderstood code, I think, don't you?
I totally agree. And that's a lot of where the question come from. First, I would like to ask a couple questions to Ron Teri. How was, I think one of the major components for billing 77412 is active motion management, which perhaps we can talk about in a little bit. Ron, Teri, how was active motion management typically billed in the past?
This is Teri. Yeah. So in the past, active motion management was challenging because it really was represented initially by a Category 3 code, which is not typically recognized by payers. That's usually considered experimental. And then it was converted to a code for those in the freestanding center, a G code, but it was still carried that legacy of just not being accepted and not being recognized. But it had an individual code that physicians could report for, when they're performing this active motion management. And there was, it really is a part of IGRT, the image guidance that is performed. So there's that opportunity. So that really in and of itself hasn't changed. There's a lot of different vendors and technology that's out there. So there's different ways that people may be utilizing this, but historically it's had a code, but it's been challenging. And I think now with just one code, what if the physician's going to bill for it, or now being tied into treatment therapy, that really gets into the utilization for this particular service, enhancing the treatment delivery.
I think one of the nice things is the way the new codes are set up, and in particular 77412, there are some opportunities to really utilize this in both 3D and IMRT.
Yeah, Ron, this is, you hear a lot of negative out there about this, but I know that, I'm sort of a glass half full guy. How do you see the good side of this?
Dr. Jahraus, thanks for posing it that way, because there are some negatives out there, but really this is an opportunity as well. It's an opportunity when you've got a patient, let's say it's a breast patient as an example, and you have tangents, you have a superclab, you have a PAB. They're all different isocenters. It's a little bit time consuming. You're doing the right thing for the patient, taking care of everything. Immediately, this is available for 77412. And so it's not just that it has to be IMRT or it has to be some other complex treatments. It can be 3D or IMRT. And the fact that it's multi-isocenter allows you to use 77412. The other opportunity, which I'm sure Teri can give some different and additional examples, is benign disease. So if you've got a patient and you're helping them with arthritis or whatever the case may be, and you've got a shoulder and a hip, that fits. It's multi-isocenter. That's going to be a 77412 as well. And the thing is, that's not additional documentation. That's not additional hardship. Just the fact that you're doing it in and of itself qualifies, and it's multi-isocenter. Now, the understanding, of course, is that you're doing, concurrent simultaneous treatment. They're not different treatments followed by each other. But still, I think that's a lot of good news out there.
I think that this is a really important distinction and point that we're trying to make here, is that 1.2 really is based upon the time it takes on the machine for that patient to get the treatment that they need. So I appreciate what Ron is pointing out, that we don't really have to rely on IMRT anymore as a technique to help us help that patient and reach a particular billing level. 1.2 is more about, go ahead, sorry. 1.2 is more about making sure that we're doing the right thing for the patient, so that it could be 2 OA sites, like Ron mentioned. It could be 2 palliative sites, like a femur, like a shoulder, done at the same time to alleviate the patient's pain, number one, and to help them with their disease, and then also bill at that higher level because it takes more time on the machine, more therapists involvement. There's just a lot of different things involved with having that patient on the table for a longer time. Right. So I think there are opportunities for utilization of this code to really do what was intended, which is treat the patient appropriately. Now, the code itself, Scott, we had looked at utilization across the 3 codes, and I just want to point out that this code was intended to be used about 35% of the time, which is about a third of the time in a clinical practice setting. And I think what we do is complex, and this helps to take away the technological part of it, meaning the IMRT versus 3D, and really focus on what we're doing for the patient. So I just wanted to make that point.
Scott, if I may just jump in here, Tarita, you and I have talked a lot about the fact that, how we get this comes about by surveys. Do you just want to comment a little on the value, or Ron or Teri, any of y'all, you want to just comment on the importance of responding to surveys when
Yeah.
codes are being developed?
I think this goes back, probably you have had a podcast on this already about the history of how these CPT codes come about, but there are 11,000 CPT codes, and they routinely have to be reevaluated for payment. And it makes sense, right? What people used to do in IMRT years ago, step and shoot, is not what we do today. The majority of the time, I'd say it would be a minority of the time we do step and shoot, and we do mostly, VMAT and a much more complex IMRT. And because of that, these codes have to be reevaluated. And as they are reevaluated, societies like ours, ACRO, ASTRO, are all involved in the process of trying to develop what that code means and what's the time involved in accomplishing that task that we're trying to do. And that's the key thing, is that we look to our colleagues to give us information about how they're actually practicing. So, one of the codes that was recently reevaluated had just 102 respondents for the survey. Okay. That was, let me just go to that. That was code 77387. Is that right, Teri?
Yeah, the IGRT code. Yeah.
And that had just 102 survey respondents. And you think, how many radiation oncologists are out there? 5,000.
Over 5,000.
Yeah.
So that response rate, now that we're seeing potentially effects that are concerning, there's of course more of an interest in understanding how that sausage was made, so to speak. But being involved from the beginning, I think, is a very helpful thing for all of us to do. So, Chris, I hope I answered that question.
Absolutely.
Well,
And if I could just
also
add
speak
to
a little bit
what
earlier when we were talking about using, HOPS, the Hospital Patient Prospective Payment System, to kind of set the values even for the treatments. They're surveyed in a very different way. But I think it also speaks to Medicare shift and how they're valuing some of these services and how they're looking forward to things and because of surveys and really wanting and hoping, expecting for a lot more participation in some of the surveys overall in healthcare. And so it's valuable that as a physician, if you get a request to fill out a survey, that you take the time. And they typically don't take more than 20 minutes. So, taking that time really is going to benefit you as a practice in the long run.
Absolutely. So as in a healthcare system, healthcare as a whole, we have about 5% of physicians responding. But if we looked at radiation oncology specifically, we have 3%. And team, I talked to some residents. We were doing a different podcast for some residents, and we went over this and we tried to educate them early on in their career. When you get out and you're an attending, you as even a brand new attending can have a voice, can make a difference, can show change. And it's so valuable for new practitioners to get engaged and involved early on before they reach a point of frustration, so they can say, hey, you know what? This is about me. I can do something here. And that their response, those residents were, you know what? I didn't even know about some of this stuff. I didn't know about proposed rules. I didn't know all that work that Dr. Jahraus and Jason are doing over at the RUC and all this kind of thing. But now that I do know, I'm going to research it a little bit more. And we can empower those who can respond more than 3%, because it makes a difference to our entire specialty, but also their individual paychecks.
Yeah.
So,
Well,
to go ahead, Chris.
No, please.
Yeah. So, just to highlight, Scott, since you asked the question for 412, multiple ISO centers. Okay. And I think we've demonstrated that with the conversation so far, including in the setting of benign disease. Okay. The other area is with active motion management, and it has to be active. Maybe Ron or Teri or Chris can speak a little bit more about that.
I'll let them talk about that, but I just want to say that the catchphrase that I've used, and Ron and Teri, you can certainly tell me whether or not this is legit, is it's not patient movement management, it's physiologic motion management. Do you think that's fair?
Excellent, Chris. You know what, Chris, from different presentations that I've gotten a lot of feedback just from the public even my own coworkers who believe, really the way that you've presented about active motion management in 412 has been excellent. They're like, he really needs to, they get it once you're explaining this. So I think, kudos to you, and don't,
Thank you.
you should be the one really speaking to this as well. So, I think that's a great analogy. It really is the physiology, and it's not just the,
Right.
The patient, I've gotten questions if a patient coughs, is that going, can we, because maybe they've got a sore throat or something, or where we're, you really have to think about, just because we can doesn't mean we should all the time, right? It does have to have its place, and it does have to be medically necessary. And that's a kind of a nebulous term. I get it.
No, but that's something I've heard you and Ron say a lot, is medical necessity is key. And, I had one group ask me, well, we use surface guidance or whatever for our brain patients. Oh, hang on. You give me an opinion on that, Ron. It didn't quite make sense to me. That's
what the mask is for. You're getting paid for an immobilization device that's complex.
Exactly.
So that's what that's supposed to be doing. If that's not working, then there's something else in the process or something else going on that your mobilization is not doing what it's intended to do. And so this doesn't supersede that, because, that breakdown.
And Ron, wouldn't you agree that you have to have some level of differentiation between codes? Because otherwise, if it were just patient fidgeting, you could bill 77412 for everything, which would wouldn't it destroy the code?
It would destroy the code. And what would end up happening, as this whole team knows here, is that our utilization would skyrocket. And as soon as utilization, Dr. Thomas mentioned a little bit ago that the expectation would be about 35%. If this code all of a sudden turns into 75 or 80%, for example, what's going to end up happening is that utilization is going to drive our revenues down. So that damages everybody. Just for practical examples, we did talk about 412 and active motion management. Certainly anywhere in the abdomen, lung, those kind of things are, absolute candidates. Other things is, what if we had a lung and a preventative brain treatment simultaneous? That is also going to be an example of 77412 for multi-isocenter. And again, I'm just trying to think of sort of examples, and I thought Dr. Thomas did great with not just OA, but if there are multiple, all of us see from time to time, you've got the patient who's got a rib and a shoulder and a knee, or, two different knees that are not able to be in the same field for whatever reason. Sometimes they are, but sometimes they aren't. And it just, you've got to see what's going on with that individual patient. And
so maybe we can give another example for Scott in terms of, active motion management. So suppose I'll give two examples and ask our experts to provide some answers. So fiducial placements for a prostate cancer patient who is getting, a 5-fraction SBRT, versus a fiducial placement for a pancreatic cancer patient who is also getting a 5-fraction treatment. Would those be considered 1-2?
Well, if it's going to be SBRT is going to have its own codes.
Right. So that's a good point. That's one of the points I wanted to make sure and make. What if you have that same prostate cancer patient, but instead they have fiducials, but they're doing a hypofractionated 28-fraction course? Would that be considered active motion management with a 1-2?
There is some, and Dr. Jahraus, anybody else can jump in too. There are some capabilities with systems that can do the continuous imaging of those fiducial markers throughout the delivery. It would not be you're taking, images, stopping the beam to take an image to see if they've shifted. This is a continuous, when it comes to those fiducials, the tracking, and it's throughout the whole delivery. I've seen different discussions, even ACRO has talked a little bit about this, and support that there may be those opportunities, but that technology in relation to that active motion management would really have to be there to be supported. It's not just a patient with fiducial markers. If you're doing that imaging alignment, that's really the IGRT that's happening before the treatment delivery is on. So we're talking about the motion. There has to be that tracking throughout the delivery. And so this may or may not you really have to kind of look into what you're doing, I think, technology wise.
I agree. I agree with Teri totally. And, just from practical examples, if you have a thin patient in a thin diameter and you've got fiducial markers, that's one thing. But if you've got, with all due respect, if you have a very obese patient and they've got fiducial markers, it is possible that that prostate could be, because I've had physicians talk to me. It's like, well, Ron, normally and generally, prostate's in place and generally no issue. On this particular patient, we've got some prostate that's shifting, a couple of centimeters.
So
And
there's an exception to every rule that's potentially justifiable.
Yeah.
exactly.
Yeah.
And
So
I guess
I-
that's the
Back to
whole
what you
point,
said
Dr.
earlier about that
Jahraus.
physiological, need to be able to make sure that we're for that particular patient. We're for just a run of the mill, and any other patient, that may not be the appropriate course and appropriate way.
To just step back for a second, for Dr. Chen, just to make sure that we're answering his question here. I mean, is it right then to say that for 77412, the sort of main couple of distinctions are, one, that you've got multi-ISO center, and two, that you've got active motion management? Are those the two kind of big things that differentiate, or is there something else we're missing here?
So no, those are the two, Jason. And the third one is mixed electron photon. I think that's an important opportunity for us to do what we can to help our patients. The most common example would be a 3-field breast, who has a wide kind of chest expansion, and you could of course consider VMAT, but then the lung dose might be too high, and really maybe the photon electron match is the best thing. Now that takes a long time on the table, okay, and that justifies the 1-2. So mixed energies, multiple ISO centers, real motion management, breath hold technique, those sort of things. I really wanted to make sure we address that prostate question, because I think that is something that maybe Teri and Ron, you might have heard a lot of questions coming in on that.
Yeah.
But I think there's a lot of opportunity with 1-2 for us to do the work we need to do to treat our patients the best that we can. And these types of changes, although they're hard, and we have to continue to wrap our head around how we're being reimbursed for them, how appropriate they are. I think they're done in the spirit of trying to do what is right for our patients and for our profession, as these codes continually get reevaluated, like I mentioned, through this AMA CPT editorial panel process, followed by the RUC every 5 years. So it is just, as we are continual learners as physicians, there's a continuing understanding of what our work is valued at.
Just for the sake of being 100% complete, there is one additional thing, and that is total skin electron therapy. I certainly do not do that in my practice. That's, I think, kind of a university
back.
thing.
I did that as a physician therapist back in the day in a couple of different university centers that I worked at. So
there you go.
I've done a lot of TBIs. So yes, total body.
So, but Dr. Jahraus, very different than the previous code said, right? Which was based on mega voltage, based on the kind of machine you had. It's fundamentally different.
The good news here too is that this is only mega voltage coding. So, all of we've heard a lot about different practices, some dermatology, for instance, using kilovoltage, and some concerns that, are some of our codes getting diluted. Now they're better separated out, so that utilization is really more commensurate to, the reimbursement is related to the utilization of individual codes.
Well, Dr. Chen, did we answer your questions today? Did that help?
Wonderful. Yeah, I have learned so much today. And if I could just ask another clarifying question in a case scenario that recently came up. So I do a lot of lung SBRT, and as part of that, we use two platforms. One is with fiducial tracking, a robotic system, and one with a linear accelerator without fiducials. So of course, it sounds like from the discussion we just had, the one with fiducial tracking during each fraction might qualify for 412.
But if it's SABRE or SBRT or whatever you want to call those things, 77373 things, then that's a separate thing, right? Right, Ron and Teri?
Absolutely. And Dr. Chen, I think that's a very good question, but as I think you just described, it's going to be SBRT. And in that scenario, you're better off, not that it's about financials, you know clinically best, but the financials are better for you to stay with SBRT, the design of what you just described.
You're doing the work that's a lot more too.
Yes.
How about with hypofractionation, for example, 8 to 15 fractions, which I also do frequently?
That's where, yeah, I mean, if it's that same kind of lung patient in that particular scenario or something similar to that, if you're into that fraction range and you have fiducials, but you're into that area where you're going to be, as Dr. Jahraus mentioned earlier, I mean, impacted by that physiological impact of the motion, and you're looking at those fiducials, or you're real-time tracking them, or you're going to be doing whatever active motion management system you have to check that respiration. That's where you get into that 412, but just making sure you've got your documentation, those orders that really show that. But yeah, that's where that 412 can come into play.
Gotcha. How about without fiducials?
Yeah, in that scenario, and if you're still using some kind of system to track, that motion, because that target is going to move as we breathe. It doesn't move just up and down, right? It moves in multiple planes, and so to be able to better, track that for what we're planning to make sure it's in the beam where it needs to be, yeah, that's where you can get into being able to support that 77412 with that system to do that.
Folks, we are coming to the end of our time here for today, but I just want to thank Dr. Thomas and Ron and Teri, and I want to especially welcome Dr. Chen, not only to this one, but to future of the Greetings from the GREC podcast. And with that, I think we'll call this one a day. Thank you for joining us for Greetings from the GREC. Everybody take care.